So I thought what we'd do this morning is just starting to talk about the situation about how our quality improvement project started. When we were completing performance appraisals for a lot of our ANUMs in the unit, they were commenting on the amount of time that they spent out of the unit attending MET calls. This often meant leaving CCU with junior staff being responsible for the patient in the unit, and as you can imagine, it was hard enough trying to respond to the MET team as well about what was worrying about what was going on back upstairs. So to give you some perspective, our critical care unit is a 6-bed unit. There's 2 high dependency, 2 coronary care and 2 ICU beds. At the time of we started looking into this, our liaison nurse only worked 0.7 EFT, worked from 7 till 4:30. Our nurse in charge took a patient load. They were not supernumerary. Our unit manager was actually supernumerary at the time, but also oversaw another 3 departments as well. So hers was basically an office role, and she wasn't always there to help out. And we only have 3 staff on a shift. Obviously that changes depending upon the acuity of our patients. If we have any one-to-one, then we flex up. So what we did was we looked into a couple of areas. So our track and trigger observation charts were not used correctly on the wards. There were many times when the obs fell into a trigger zone and that wasn't actioned on. And we also looked at our treatment limitation orders, that this was also a common theme amongst our staff. That we looked at that a lot of the time we were going to MET calls at 2 o'clock in the morning, there'd be no discussion about treatment limitation orders. We were waking family up at 2 o'clock in the morning and asking them to please have these discussions with us if the patient wasn't able to. So with our track and trigger charts, what we did was we had a look at what our triggers were. At the time we had 4 actions, so we had increased surveillance, telling the unit manager or the ANUM that was in charge of the shift, a medical clinical review, and then our MET call criteria. So after discussion with staff, what we did was we changed this to 3. So we took out the increased surveillance, which obviously we would do, but we also, the first action is to tell the nurse in charge, this way that she was fully informed of what was going on in the ward at the time. So what we did was we did audits. So we looked at our charts, our observation charts, and with every MET call it was entered into our riskman system. We looked at what the observation charts were showing us for that 48 hours prior to the MET was being called. So what we actually did was we sent, if there was something that wasn't actioned, we actually sent it to the nurse unit manager who called the staff that were looking after that patient up and made people accountable for what their responses were. So, okay, it was meant for a medical review, that didn't happen, why, what was happening, so that we were sort of acting on triggers a little bit earlier. The other thing we did was educate. We educated everybody. We had in-house education. We had outside education. And the other thing we did as part of our productive ward in our critical care unit was we also looked at, did we need to modify some of our MET criteria when patients left the ward. So if we had somebody that had a blood pressure of 90 and that was our MET calling criteria and that was normal for them, did we change that to 85? And these are reviewed every day by our medical staff. So we looked at that. For our treatment limitation orders, once again we educated everybody, and I think we played a bit of a big stick approach for this. So as we have rotating medical registrars, and as we are a fairly small hospital, what we did was do a lot of education with them. So they received education on their orientation day. These are our treatment limitation orders. We would prefer it if you filled them out on people early rather than later, and the reasons why. The other thing with our treatment limitation orders that also went around with our medication, which is a side step, is that a copy of our treatment limitation orders are sent to the GPs on discharge along with the discharge summary, hopefully to start a conversation maybe on advanced care planning if there's limitations of treatment there. So it was important that they filled them out properly and they filled them out in a timely manner. We also had a lot of buy-ins from nursing staff for the ANUMs and CCU and ED to remind the doctors that the form was basically shoved under their nose if they thought it was appropriate for that patient. So a lot of it was nurse-driven. And we also provided education to the ward staff as well on if they thought someone would benefit from having a treatment limitation order or having that conversation with family, then it was brought up with the nurse in charge and the doctors on rounds. So, what did we accomplish? We showed through auditing that our treatment limitation orders were being filled out in ED and CCU approximately 6 to 9% of the time, or increase, so that was very beneficial. Our MET calls decreased over the first 6-month period of our big education blitz by more than 43%. So we found that people were actually actioning things earlier. They were getting the medical reviews, they were doing increased surveillance in their OBS if they needed to, and talking to the nurse in charge. And we also had improved compliance with our track and trigger charts. So what we did was every month we pulled so many histories from patients that were currently in and had a look at these OBS charts just to make sure people were actually doing the right thing. So in theory it all sounds good. Is it sustainable? Our education on the track and trigger charts and treatment limitation orders are still part of the orientation process, and that's for medical and nursing staff. We do audit them, especially if we have a new lot of medical registrars come around. Normally within the first couple of weeks we'll go and have a look and make sure that they are filling these forms out correctly. And we're even getting forms that are there with patient wants full active treatment written on it. So at least we do have an idea that the conversation's been had and it's been documented as well. So our MET calls have increased in the last 12 months since this project finished, but they're still 34% lower than the original number that we looked at. And they do sort of wax and wane. We did see an increase in MET calls not long after our new lot of grads started, but with more education on the deteriorating patient, they've backed off a little bit as well. Our treatment limitation orders have increased. Overall, we're having a lot more treatment limitation forms filled out on patients during hospital admissions. And we're still showing that a large proportion of those are filled out in emergency and critical care. So it seems like it's still working. That's a graph of what our METs and codes have done. Unfortunately, it does show our METs and codes in ED, which we still do call. CCU nurses don't normally attend those. It's more to get the medical staff there depending on what specific MET that we're calling. So whether it's a trauma MET, we want the surgical team. A pediatric MET, we want the pediatricians. Or an obstetric MET that we want the obstetricians to attend. So we've shown that we're decreasing our numbers, which is good for our staff. And things have changed in our unit too. Our in charge is now supernumerary, so it frees us up a little bit more without worrying quite so much about what was happening. So that's a very brief overview of what we did at Central Gippsland Health Service.